Welcome, everybody, to our Wild Smoke and Lung Health webinar. I'm so grateful to be joined by all of you joining us online, watching this either now or later. Today, we have some excellent presentations on the topic. But first and foremost, I want to acknowledge that we are coming to you from the unceded and traditional territories of the Musqueam, Squamish, and Tsleil-Waututh nations, where we all get the chance to work, live, and play. And really, what this webinar is about is stewarding those lands appropriately, that environment appropriately, especially when it comes to wildfires and its impact on our health. We have a great slate today. We have two members of our BC Lung Medical Advisory Committee who are going to present to you. But to facilitate all of this, I'm going to introduce you to Dr. Eric Coker. He's the Senior Scientist in Environmental Health Services at the BC Centre for Disease Control. He's the personification of when science meets fresh air. With specialized expertise in environmental epidemiology, exposure science, and maternal child health, Dr. Coker's work zeroes in on how air pollution and other environmental social stressors shape our health. And his passion is tackling health disparities and uncovering how inequality seeps into the air we breathe and the communities that we live in. So without further ado, Dr. Eric Coker.
Well, thank you, Chris, for that warm introduction. I am happy to be here today to facilitate our excellent conversations with two excellent presenters. I also want to acknowledge that I'm here on the traditional and unceded territories of the Musqueam, Squamish, and Tsleil-Waututh nations. More broadly, we're known as the Coast Salish people. So let's jump right into our first discussant today. We have Dr. Chris Carlston. He is a professor of medicine and head of respiratory medicine division in the Faculty of Medicine. That's a lot of medicines at the University of British Columbia. He is the director of the Air Pollution Exposure Laboratory and the Center for Lung Health. The Carlston Lab focuses on the respiratory and immunological health effects of inhaled environmental occupational exposures using diesel exhaust, western red cedar, and phthalates as model inhalants. Dr. Carlson we're fortunate to learn today about the potential differences of particulate matter by source, wildfire smoke, and traffic-related air pollution. A really nuanced, important topic. So I will hand it off to Dr. Carlston. Um, who may need to switch out of presenter mode.
Oh, I'm still in that one. Okay.
Okay.
I thought I could be a little bit smarter, but let's just go back to the
Yeah.
traditional. Okay, cool.
Okay.
Thanks, Eric and everyone.
Yeah.
As you heard, I'm Chris Carlston. I'm sure I know some of you and certainly not all. It's a nice big audience as BC Long tends to bring in for these, thanks to the organizers. This is the nominal topic, and I do think it's going to be the sort of centerpiece of what I want to say, because I think this is becoming an increasingly important issue, meaning, how is wildfire smoke different from trap? And by trap, I mean traffic-related air pollution, to be clear. So basically, I'm going to talk about um, some of the basics of where particulate matter comes from and some of the basics of the outcomes. But really, I want to spend not necessarily most of the time, but most of the focus on this idea of smoke specificity. Again, how is smoke different in terms of how it affects our lungs in particular? What's the evidence for that? What evidence is missing, et cetera? Um, and I hope that's the big take home point from this before I hand off to Emily. Just some basics. Again, a big audience, and I don't think everyone is totally familiar with this, although it's become, I think, pretty common understanding what we mean when we talk about PM or particle matter. So let's use this graphic of a human hair. We all know what a human hair is and looks like when you hold it or hold it up to light. And this is nice just to get down to what these sizes really mean. So you can fit approximately 5 PM10 across a human hair. And then you can divide one of those in 4 parts, of course, dividing 10 by 4 and get PM 2.5. So 2.5 microns in diameter. So it just gives you a sense. And those are the ones that can get deep into the lungs, and then across even the alveolar barrier into the blood for those interested in the cardiovascular effects. That's at least part of the reason, though, certainly not all of it. So that's just a little bit of a basic framework. Um, where do these particles come from? Here's a schematic just to try to divide it into some basic categories. So we're going to be talking about fires or obviously other sources of combustion and particles in the environment. There's agriculture, et cetera. And again, what we've talked about a lot for decades and put a lot of energy into is transportation and what happens when gasoline or diesel exhaust or other fuels are combusted, and that's an ongoing problem. But fires are really justifiably taking a lot of our attention now. So here's another basic, just to make a couple more points about this. You'll see again the size graphic, and now those 2.5 in diameter, 2.5 micron in diameter particles, you can divide even further into 0.5 micron. And so when a tree burns, along with whatever else burns with it, there are going to be these types of agglomerations, and then they're going to stick together to make what is known as a particle, but really is a collection of smaller particles. And that's why the aerodynamic diameter that people will talk about, 2.5 microns in aerodynamic diameter. So that's basically how it travels through the air. Importantly, though, what happens after the fire starts, so at the tree, if you will, and it spreads and dilutes, is that a lot of photochemical changes. And I'm going to refer back to that later. So it's important just to set the stage for the fact that there's one thing at the source of the fire, so proximal or near to the tree, and there's another over time, which can be days, as these particles, as you'll see, can actually travel not only to Eastern Canada or the US, but all the way to Europe and even Africa. Incredible enough, but that's been increasingly documented. It's also important to recognize that it's not just the trees, as I alluded to, it's whatever else is around them. And as these fires approach urban or even suburban, any kind of man-made dwelling, then now you're talking about burning paint and metal and plastic, etc. So it becomes quickly very complicated. Again, a basic is just how impactful these particles are on human health. So lots of data on this figure, but just in terms of particles overall in the air, what we call ambient air pollution, PM 2.5, it's the biggest killer of anything in the environment. So you can see the various other common things that we typically think of, and you can see how dominant is PM 2.5 in the air. It's also, of course, problematic inside homes. You put these two together and you get PM 2.5 in general being exceedingly dominant. And, you know, these are other important things, obviously, but even if you look at temperature, which of course we're concerned at, pretty small in impact relatively to the various PM constituents in the environment that we all face around the world. How much of that is from fire smoke? That's really been a big question that is increasingly understood. So we know that a lot is from fire smoke when you see an event like this, certainly close to the source. And again, remember, this evolves over time as it goes from, in this case, Alberta onto other provinces. But in terms of the impact, this is, I think, a really nice way to look at it. You can look at the entire US, and I'm going to choose Northwest as a section of that because, as you know, the Northwestern US is just across an arbitrary border with BC and et cetera for the Rockies and other provinces. But really what the pattern that you can see is a improvement over the years up to approximately 2016 and even before that. But for this graphic, we're looking at since 2000 and this improvement that inflects and goes in the wrong direction. We all would agree, the wrong direction in the sense of worse air quality, such that at least in the US and pretty close to this in Canada, again, for reasons of this being an arbitrary border, up to half of the PM is now coming from smoke, depending on how you average the time, et cetera, but a huge portion. How are we measuring this? Again, just so people are aware, because I'll show you some data that you can get on your own phone, et cetera, and you might want to know where this comes from. It's a combination of data points, thankfully, cooperation from different jurisdictions, as you can see. And traditionally, these stations in various communities strategically located. But nowadays, data is coming also from satellites, as you can see here, organized by NASA, from individuals who contribute by having devices like this purple ear device. And you can see a map of purple ear. This is from Washington State, but you can get this in various jurisdictions. And then it can all come together on applications like this and others that are in the US and other places where you can see the contribution of purple ear and other similar devices, or the agency monitors that I mentioned before, and you can see the color coding and some hotspots, et cetera, on a given day and time. That's helpful because of events like this. Is the Gran Fondo, the Sea to Sky corridor. Many of you are familiar, and this is that corridor, and these are some nice numbers, but unfortunately at that time it was the perfectly unfortunate timing of air pollution spikes that you can see here. And of course, lots of questions about whether the event should be held. You can see the smoke in the air here. Obviously, you can see that many still did it. And it brings up a lot of questions that Emily will touch on in terms of susceptibility and how we advise people in these events, which is not an easy thing to do. But the big pattern, of course, is that the air quality is unfortunately worsening for all the reasons I mentioned, while the World Health Organization and others is actually saying that we should aim for even the cleaner air quality. So kind of opposite trends, unfortunately, there. The data showing that these types of movements down in terms of our standards are likely to protect health as we get more and more resolution on how going even lower is actually beneficial, down to practically background levels. And again, the air quality going in the opposite direction, unfortunately. And we're in the heat of it here. Heat and smoke of it, I suppose, in BC, something we elaborated on that paper. And it's because not only of the climate and the fires, but also because I think we have really good research and cutting edge. For example, this paper, which was really ahead of its time. There's been quite a lot since, but in 2011, I give credit to Sarah Henderson and others as groundbreaking, not only in general for the work they did, but just how well they communicated. So you can see here how easy it is to understand, I think, the relationship between particulate matter with this black line and physician visits for asthma. And I highlight the word asthma because, as you'll see soon, one of the clear and outstanding signals from fire smoke is its relationship to asthma in particular. Certainly other diseases, but asthma in particular. And here's just a snapshot of the explosion of papers that have come out. You can see throughout this asthma, etc. And it's really been remarkable how strong the signal is for asthma in particular. And again, I'll refer to some other respiratory and even cardiovascular conditions, but I think the signal for asthma is important for reasons we'll get to in terms of the original question at the top of the talk. How is fire smoke different? Here's asthma again, and this is in terms of percent increases. And you can see the various conditions, all respiratory or airway, if you will, including the upper airway and the ear, nose, and throat connection to the lower airway. Asthma again stands out. It's well above the line of 0% increase, and it could be even up to 200% increase depending on how you look at it. And the other thing to sort of step back and look at is how much more clear it appears so far the respiratory signal is to cardiovascular. And in general, that's the opposite pattern from traffic-related pollution. So if you had to make a high-level statement, looking back over decades of data from traffic-related air pollution, the impact is disproportionately higher on cardiovascular overall than airways, and it may be that the opposite pattern is true for fire smoke. And again, we'll suggest maybe some of the reasons for that, because it does beg an explanation. This is a study that relatively early on, at least in terms of this question of, is sort of particle per particle, or the way we look at it as microgram per cubic meter of PM 2.5. Again, those small particles, or apples to apples, if you will. Is fire smoke worse? And this was an early sign, not the biggest or probably best study methodologically, but something to credit from relatively early in this question of is fire smoke worse? And this paper concluded that approximately 10 times worse indeed was the case for children's respiratory health conditions. But I want to turn to more recent studies that I think do a little bit of a better job and go into more detail, especially given the limited time we have. So I'm going to focus on this one in particular from this year, from Wang and what we call the Blue Journal. And they did a really nice job in several ways. First of all, a rather long period of observation, retrospectively, but still more than a decade of time that they looked into in terms of Western US and fires. And importantly, again, in terms of the size of the study, 6 million emergency department visits, specifically for various respiratory diseases. And I'll show you what those are shortly. And then the exposure was, I think, pretty good, in the sense that they used not only machine learning, which has its advantages, but they looked for ground truth by other methods to cross-reference it. And so they had a pretty sophisticated and I think valid exposure parameter, and what would be standard, but I think appropriate in terms of the model, the case crossover design. And here again, you can see asthma standing out. It's at the top in blue. You can see odds ratios that are also elevated for other conditions. Like I said, mentioning other conditions, COPD, or total respiratory, et cetera. Even looking at bronchitis, it's hovering above the line of 1.0 in terms of odds ratios. It seems a bit elevated, but asthma really stands out, as you can see. And the other thing that's remarkable here in this study is what appears to be a lack of a safe lower level. So you can see that for every initial microgram per cubic meter of PM 2.5, you get an increased risk, and it's fairly linear. The other thing that's interesting is, since they looked at such a huge area, the Western US, and many of those places were far enough away from fires, that the PM 2.5 was still dominated by traffic. If you look across that entire region, the days where the frequency of smoke raised the PM level by anything more than a few micrograms per cubic meter were few. But those individual units of microgram per cubic meter were more influential. And that's really the key point to this. So for example, if you look at just for asthma, the odds ratio for a given microgram per cubic meter for smoke, 1.02, and tenfold less for non-smoke. It's interesting that that's that same tenfold that was shown in that 2021 paper, which I said was groundbreaking, but a much smaller study, and you could consider it essentially validated in broad terms by this paper. There's a couple other things that I skipped over to get to that point about the tenfold difference, and I just want to come back to that. This large study with 6 million people was able to look at things like sex-based differences, so females being more susceptible, and even adults versus children, which is interesting. It's kind of the opposite of what we often think. But with that kind of data set, you can look at these effect modifiers, which is, I think, important. Now, that was larger, much larger, as I said, but still the US, and it's important to look at other countries, other regions, and this does both. Several countries, as you can see, several continents, similar time frame. And again, here's asthma, and it looks very similar, doesn't it? You can see again, this is a relative risk as opposed to odds ratio, but same basic concept, that relatively linear, little protection even at lower levels, and COPD, respiratory infections, influenza. So there's a whole literature about the risk of infectious disease, probably due to immune system changes and other factors biologically that come with fire smoke exposure. So you can see all these in this really nice study. And also, if you read the paper, that if one were to just pool all the PM, like we traditionally do, we measure PM in the various monitors I showed you before. But by whatever technique, if you just grossly measure PM and don't know where it's coming from, you'll underestimate the fire-related portion by almost 100%. So this all kind of the different ways of saying something similar, that fire, smoke, microgram per cubic meter versus other microgram per cubic meter seems to be worse. And there's some evidence really coming together to support that. But still, those are observational. The studies have gotten better and better, as I mentioned, but nonetheless observational. And so we're always pushing for plausibility to back up these findings. One way to do it is through controlled human exposures. I'm just going to briefly touch on that because it is a critical way we believe in the community to back up some of these observational findings. This is a way to look at it graphically. I'm not getting at this point into animal models, but I'll touch on a cellular model example briefly to again complement epidemiology. For the controlled human exposures, in terms of smoke, we did this synthesis. Now it's about 5 years old now and hasn't fundamentally changed, but I just want to give you a couple examples of the kinds of studies that we can look at to ask, okay, are these observations plausible? And again, by that I mean, do they make sense? Do they hold up in a different model where we have more control over what we're doing and less risk of confounding? So this is an example. All these studies are essentially similar, different places in the world, different labs, but essentially similar in that they'll take a small group of individuals and use them as their own controls by on one day giving them clean air and on another day wood smoke. This is the kind of thing that we do here also in Vancouver, and there's just a few places around the world that do it. But by doing so, even with a small group, because they're internally controlled, you can definitively say that the reason for this serum amyloid A, which is an inflammatory protein, is because of the wood smoke. These are the same people that are just coming back on different days. And so if this protein goes up, it really must be the wood smoke. They're not confounded in any way by virtue of the design. There are other factors, we don't need to get into the details, but other factors that can contribute to cardiovascular events and overall oxidative stress, which is represented by 8-isoprostane. I'm mentioning that because we'll come back to oxidative stress as a potentially unifying factor. There's another study, again, I know complex to just see for the first time in one slide, but the same idea, crossover, a small group of healthy volunteers. But what you see is this one unique going into their lungs by BW, meaning bronchial wash, or BAL. These are just two different ways of sampling fluid from the lungs, but really directly looking into the lungs and seeing that with that wood smoke, you get more neutrophils. And neutrophils are just a critically fundamental element of inflammation in the lungs. So really definitive evidence of that inflammation from wood smoke. And then, as I said, oxidative stress. So you don't have to know too much about the biology. Just understand that this big white bar right here is not inhibiting oxidative stress with wood smoke. So when you do inhibit with these two different techniques in gray oxidative stress, you knock it down essentially. You knock down this oxidative stress signal down to basically the control or saline. So you can kind of see all down here is roughly these lower levels, and boom, when you don't inhibit oxidative stress with wood smoke, you get this big signal. And this is just another way of looking at it over here and showing that the higher dose, the more oxidative stress. So it's again that plausibility. There's clearly oxidative stress from wood smoke. And this is, again, wood smoke that is just fresh. It doesn't even get into that aging that we'll come back to. And I mentioned early on, as the plume moves away from the tree across the continent and atmospheric aging happens. So the particles are smaller, at least a higher percentage of ultrafine particles with wood smoke. That's one thing, getting back to that early slide about size. And they do different things. They clearly do different things. Again, detailed biology here, but you can just kind of look from a distance and see that the names of these different genes, these are different genes that we measure what's called gene expression. This is a cell culture model. I mentioned that I would briefly touch on cell culture, but you can do these things efficiently rather than a multi-year long human study, and just simply show that the different genes that are expressed in epithelial cells, these are the cells of the human airways, are very different whether you're talking about traffic or fire smoke. But it really is going to depend on what is being burned. So this is just that lodgepole pine being freshly burned. If you, however, age this, so this is getting, I'm not going to get too much deeper into this, so just bear with me for this last kind of detailed biology part for the time being. If you age this, and so aging, you can see the word aged right here, whether briefly or more importantly, on a longer time period, this is basically recapitulating a fire plume that goes across the continent of North America to Eastern Canada or the US. It doesn't always take 11 days, but that's a reasonable time depending on winds, etc. And there have been examples over the last 5 years that this has been modeled. We can show that with that aging, the toxicity, these are inflammatory proteins, you don't need to know the details, clearly goes up in blue. And so it's really important to try to contextualize the work that we're doing, whether it's in the lab or otherwise, to fit the epidemiology and vice versa. And that's that plausibility that I mentioned. And we're going to take that now with that background level, with that background data, excuse me, and context to another one of these studies that I showed you previously from Sweden, et cetera. But in this one, uniquely taking the same individuals and comparing them to comparing them being exposed to wood smoke or diesel exhaust and that filtered air, clean air control. So this will be the first time that the same individuals will be exposed to the different classical types of pollution, whether traffic or fires, to see definitively, we hope, at least in this model, whether the smoke is actually doing the types of things that we've seen in epidemiology, or at least the kinds of inflammatory airway insults that would be consistent with airway exacerbations, like the asthma that we saw in the previous slides. So I'm going to come down to my last few slides just to show this more recent paper and put it into the context of occupation and workers at the front line who I think don't get enough attention. So this is a paper in Nature, as you can see this year. And briefly, what it shows is that, not surprisingly, the 2023 Canadian fires most heavily exposed those in Canada. After all, they were Canadian fires. And so this dark color here is the, you can see here the percent of individuals exposed beyond a certain threshold. But you also see that extended significantly to the northeastern US and even into Europe. Okay, so this is the important thing from this study, that, as I said earlier in my talk, the Canadian fires are clearly affecting areas beyond Canada, and in the most recent results here, Europe and even Africa, which I don't show in here. And that's important because Europe is so dense in terms of its population density that it's actually been attributed with more deaths from this event. So according to this paper, which we've reviewed and is of quite high quality, more individuals died in Europe and even North America than Canada from the Canadian fires because of population density, even though on average they were less exposed. Now, amongst them are firefighters. So I wanted to show you that paper, but I'm really connecting it to the fact that now we have firefighters all around the world who are and it's not just firefighters, to be fair. There's a lot of other occupational exposure, but there are firefighters who are increasingly asked to respond to these events. And we know that from this workshop report, and I won't go through it in great detail. We know that the data we have specific to firefighters is very poor for various reasons. They're really hard to study because they're so busy and in such crisis oriented situations. There's a healthy worker effect. They generally are relatively dismissive, not to paint them with a broad brush, but they generally are not highly focused on the risk to their health for various reasons. And yet they're breathing at a high rate, which brings in more particles. So they're really highly exposed. And it looks like this. And I just want to highlight this because this is active research led by Madden Brewster, who's a postdoc that's working with myself, Emily, and Phil Ainsley in the Okanagan. And you just see these exposures, and you can see universally a lack of mask use or respiratory protection. And we're showing, really, Madden is showing that their oxygen saturation even drops. So this is obviously a fundamental when you start dropping oxygen saturation. I'll reassure you that this is all in the sort of safe range, but nonetheless, each one of these lines are an individual. So you can see multiple individuals, and then on average, a significant drop in oxygenation. So I think this is my last slide. All of this is coming together in this grant and project, this multifaceted project called Lungs on Fire, funded by CIHR. This is due to the urgency of what I told you, and in particular that we know very little about what happens long term. So you can probably appreciate that almost everything I told you, in fact, really everything I told you, is about acute or short-term disease and events. And we know very, very little about what happens over years. So that's kind of the fundamentals of Lungs on Fire. We're really proud that we have a whole aim that's really about the community needs, and that's something that Legacy for Airway Health in particular has focused on. And you'll hear more about this into the future. For now, I'm going to hand over to Emily, and she's going to talk in particular about AIM 2.
Chris, I'm going to introduce Emily real quick. That was absolutely fascinating. Thank you for breaking all that down. Let me introduce our next speaker, who I know quite well. Dr. Emily Brigham is an associate professor of respiratory medicine at UBC. She cares for patients with respiratory disease at Vancouver General Hospital and in outpatient practice at the Lung Center. Dr. Brigham has an additional appointment as research scientist within the Vancouver Coastal Health Research Institute and affiliated with the Legacy for Airways Health, where she investigates diet and nutrition as a potential tool to reduce the respiratory response to air pollution. So without further ado, Dr. Brigham, you're up next. Thank you.
Thank you, Dr. Coker. You'll watch me go through the humbling experience of trying to share my slides. So just a moment. Hopefully, can I confirm, or are you seeing, are you seeing the correct thing?
Yep, a bunch
Oh,
of
great.
a bunch of colors. Yep.
Okay, wonderful. Well, I really enjoyed listening to Dr. Carlston speak and have had the opportunity to hear him speak about much of this, but it's great the way that these things are put together. So as he mentioned, I'll be talking a bit more about susceptibility. He's already covered the health effects, and then I'll also be going into how it's recommended that we attempt to mitigate exposure. And I would also like to just note that I am on the traditional and unceded territories of the Musqueam, Squamish, and Tsleil-Waututh peoples. I have learned an incredible amount since coming to British Columbia from those that have been willing to share their traditional Indigenous knowledge with me. It has really reframed how I think about so many things. And with that, I just want to make sure that while we are focused on human health within this discussion today, that just to recognize that really human health is truly inseparable from planetary health. And wildfires are such an important and stark reminder of that as we think about how we are approaching this problem together. I also want to thank the BC Lung Foundation for funding some research. So they are a disclosure for me. I have the privilege of working with Dr. Coker as well as Dr. Angela Yao on a project funded by BC Lung. And also my salary is partly funded by the Michael Smith Health Research BC. I love this picture. I use it in all of my slides. So this is from investigators at the BC CDC as well as elsewhere. And it really shows the distribution of wildfire smoke across North America during multiple years. And I think highlights the wide-reaching exposures that occur during wildfire season. We are all in this together as we think about how we approach wildfire smoke. So hopefully I can advance. There we go. All right. So we talked a lot about lung health, and I just want to remind everybody that truly wildfire smoke impacts many different organ systems, though I will continue to focus primarily on the lung. We know about the acute impacts that Dr. Carlston highlighted, those including things like symptoms, cough, wheeze, phlegm, difficulty breathing, acute healthcare utilization, emergency department hospitalizations. And there's also some early signal coming out about potential for chronic health impacts. There was a modeling study that looked at proximity to wildfires and demonstrating a higher association with longer-term lung cancer. But I think we're really at the cusp of starting to understand what the impacts of longer-term exposures, as Dr. Carlston was mentioning. And then we think about the heart too. So heart attacks, heart failure, increased visits for this, trouble thinking, poor cognition, headache, stroke, worsened mental health impacts, either as a direct result of smoke or due to some of the behaviors that we need to change to really avoid the smoke exposure for other health impacts. And then more and more information coming out about the potential impacts of wildfire smoke exposure on maternal health and child health, with a potential link to preterm birth. But these outcomes are not experienced equally across the population. There are individuals who may have higher susceptibility, higher vulnerability to exposure to wildfire smoke. And this is a figure that is just meant to illustrate this, really. This was a population-based analysis, and this was looking at emergency department visits in California, again in the US, looking at acute health outcomes. So what I want you to, the left-hand panel is looking at cardiovascular emergency department visits, right-hand panel is respiratory. Above that line at 1.0 is when there's increased relative risk, and then on the bottom is sort of smoke density going from left to right with increasing density. And if you focus just on the green, that is the overall increased risk that you see with higher smoke density in your area in terms of emergency department visits. But then when they took that same data and they stratified it, or they divided it out by age, and they looked at adults 45 to 64 versus adults 65 plus, what you can see is this divergence where you're seeing adults over the age of 65 in this data set actually have a much higher risk compared to those under the age of 65. And this will get into some of the health recommendations that have put out by the BC CDC and so forth. But really the point that I want to make with this slide is that not everybody experiences risk the same, and that if we don't look for differences within the population, we may be missing opportunities to prioritize and really protect. So I have to highlight some of the wonderful work that is done by the BC CDC. I think BC is really ahead of the game in terms of putting out public health messaging. So if you Google BC CDC wildfire smoke and you look on their webpage, and I know that there are links to this through the BC Lung webpage as well, but you will see a number of patient-facing and public-facing info sheets that are really aimed to provide practical advice, information, and evidence in order to be able to understand exposure to wildfire smoke and protect yourself from wildfire smoke. So I would highly encourage, if you have not seen these, if you have not looked through these are wonderful resources. They're translated into multiple languages, and there's also a separate page for extreme heat. There are also what to do in the setting of wildfire smoke and extreme heat combined, and Eric Coker has been one of the leaders in understanding some of this evidence and guidance as well. But I'd highly encourage you to take a look. And these are just examples of some of the info sheets that you might see. They're maybe 2 to 3 pages at most, and they really go through some of the fundamental topics that individuals need to be able to protect themselves in the setting of smoky days and so forth. So on the left, there's one about portable air cleaners, how to pick an air cleaner, who it might be most highest yield to have an air cleaner in their home. And then on the right, we talk about another way to protect ourselves against some of the particulates in the air, masks, how to put on a mask, how to choose a mask, which one is a respirator, really truly, because the N95s, which we term as respirators, are the ones that are preferred, but how to use those and think about those. But I want to highlight that within this evidence, again, as we go back to this idea of susceptibility, who are the individuals to which it is the most important to apply these protective measures? And BCCDC has provided some infographics down in the bottom left-hand corner. So we know that individuals living with chronic disease, heart and lung disease, pregnant persons, children, infants, and individuals above the age of 65 are known to be higher risk. We also know that individuals who have active respiratory infections may be at higher risk. But really, the evidence that we have and the evidence that's put out there surrounds what we know about acute effects. So again, getting back to this, how might evidence change if we know about chronic effects, and how can we get that information in order to best inform protection? The other piece, which I'll come back to as well, is at present, our best recommendations are down in the bottom right. Hopefully you can see my cursor. But even individuals who do not fit into one of these risk categories may be at enhanced risk, and it's unclear. We just don't know yet. But at this present time, it's really encouraged that you listen to your own symptoms. And if you are having symptoms, to seek out cleaner air. And I'll get back to that in a bit and how we think about that too. What is cleaner air? How do we where do we get this information, and how do we interpret this? How is this reported to us? So in Canada, we have something called the Air Quality Health Index. And this is a combination, it's calculated based on a combination of common air pollutants that are known to impact human health. These include ozone at the ground level, or O3, fine particulate matter, or PM2.5, which we've heard quite a bit about, and then nitrogen dioxide as well. And the AQHI formulation really captures information about acute health risks. I've highlighted fine particulate matter here because we know that elevated smoke concentrations during wildfire season sometimes cause the AQHI to underreport health risks, and therefore there was an adjustment made to the AQHI in BC, which has been translated across the nation, where during wildfire season, the PM 2.5 is really the dominant pollutant that is reported as a part of this AQHI health risks. That's automatically put in, so you can pay attention to the AQHI as well. And that is accounted for within this publicly reported metric. For those that have looked at the AQHI, and this is prevalent on the WeatherCan app and multiple places, it reported publicly. You note the blue tends to be lower risk, looking in the top right-hand corner. That goes up to about a PM 2.5 concentration of 30. Yellow and up to orange is moderate risk, and then it goes all the way up to 10 plus, which is very high risk. And you may recognize some of these colors from that map that Dr. Carlston showed earlier, which really showed some hot spots of areas that had potentially higher PM 2.5 concentrations on that AQ map. But I want to point you to this figure down at the bottom. And this is a really important figure, and I'm going to take some time to go through it. But this line here that you see is represents the rate of asthma-related physician visits per 24-hour average PM 2.5 concentration. And this is this is standardized compared to a PM 2.5 concentration of 10 micrograms or below, which is really typical of air quality in BC. So once we start to get above that, what are the increased rates of asthma-related physician visits that we see? In the background, you'll see some shading that correlates with the AQHI. So where you see this line on the map, this correlates with a low risk, typically a low risk AQHI. The yellow correlates with moderate, and then we move into higher and higher risk. And then on this x-axis right here, this is called a carpet plot, but what it really shows is the frequency, how often we see these concentrations in BC. So the denser is where we have more. So we have more in this lower range, thankfully. We do have pretty good air quality in BC, but we do see some of these higher concentrations moving through. And what I want to point to is this is not entirely linear, meaning it's not a one-for-one increase in PM, increase in risk. But we do see that even at very, very low concentrations, just as Dr. Carlston was saying, there is still a relationship between increases in PM, even in this low risk category, and the increased rate of asthma-related physician visits. And this percentage up in the top, which hopefully you can see my cursor as well, the 35.5 and 29.8, represents what we actually see in terms of how many, what proportion of the asthma-related physician visits are relative to this AQHI. So even though this is a lower risk compared to when we move farther right on the curve, because we spend more time in this lower risk air quality zone, and because there is a relationship even between changes in PM in this zone and asthma risk, we still see a high proportion of asthma-related visits at this low level. So it begs the question at where should we really be putting these metrics, these markers of risk, and how should we be talking to our population about it? We know, based on all the evidence that Dr. Carlston just shared, that lower is always better. But at what range do we start to change the risk benefit of when we ask individuals or suggest that individuals change behavior? And I think it's something that's still being worked out as we learn more. But this is where it stands currently. And so this is general guidance that's put out by the BC CDC and is very, very helpful as we think about individuals are looking at their air quality and wondering, what should I be doing with this? With different different messaging for activities for those that are considered at risk, some of those groups that I highlighted, those that may be more susceptible based on what we know now, versus those that are considered the general population, so healthy and not having any of those risk factors. With the caveat that above and beyond this, if you're having symptoms, you should not continue at the same level of activity, you should move to cleaner air. And again, these are the groups that we think may have higher susceptibility in response to air pollution and response to wildfire smoke. However, as we've said, we also, to go beyond that, we use our own experience and symptoms as a guide. So is this fair? And what else can we find out? What about the chronic effects? So this study that Dr. Carlston has led, and I'm fortunate to be a part of, is really, it's called the Lungs on Fire Team Health Grant. So the Canadian Institutes of Health Research puts out funding calls to gather groups of researchers together to focus on topics and to work together to really address an unknown answer to a very important question, which we were fortunate enough to get funding to really circle a large team around wildfire smoke. And I'm going to focus in this center circle aim 2, which is really about understanding how different characteristics of individuals, different experiences, different social contexts may impact the response to wildfire smoke exposure. So you'll see within here one of the things that we've already talked about, sex, gender, and age. So I showed that slide earlier on showing differential acute health impacts by age. We'll also look at chronic impacts and also by sex within these large population cohorts that we have available through some of the amazing administrative data that's available in BC, which is really just the health data, but then also through a large Canadian wide study called the Canadian Longitudinal Study on Aging, through which about 50,000 individuals have donated their time as participants. Thank you, participants. This can't be done without you, to really help us to tease apart some of these factors and try to understand how wildfire smoke is impacting health and how it will also have different exercise habits, different dietary intakes, whether fat distribution in the body influences how an individual responds to wildfire smoke. These things may be important. So exercise, you're breathing faster as you're exercising. You may be taking in a larger dose of particulate matter for a given outdoor concentration. Is that impacting you negatively, or are the positive health impact of exercise actually protecting you? Diet can contain a number of antioxidant, anti-inflammatory components, or it can be alternatively quite pro-inflammatory and may change the way that our lungs respond to this wildfire smoke. So we're going to take a look at that. We'll also take a look at oxidative stress, metabolism, genetics, the different ways that individuals receive pro-inflammatory and pro-oxidant exposures and how their body processes them may be important in understanding differential levels of risk. And then we'll also take a look at the communities in which individuals live. What are characteristics of a community that promote resilience to wildfire smoke? What are characteristics that may highlight those that are at higher risk and may require intervention and additional support to reduce risk and promote health equity? So in the meantime, we have to do health messaging. We still have to tell people what to do while we're learning all of this. And so this was a really fantastic study that was done prior to me joining the Legacy for Airway Health in 2020. And it was a survey of the general, sorry, I lost my slides. There we go. Survey of the general population in BC to better understand how they're receiving, understanding, and acting on public health advice. And as a part of this, respondents felt that more diverse methods of communication and really tailored messages to specific populations would improve access to public health advice, particularly for those most at risk. And importantly, a further study was done, really speaking with health providers who really wanted to be able to provide this advice, but highlighted a perceived need for increased resources for counseling. And so from that, a project was inspired that has been quite grassroots and supported in part by BC Lung. It was part of one of the earlier State of the Air reports. But taking this idea of a COPD and asthma action plan, which are guideline recommended, guideline supported plans that work with really support individuals with living with asthma and COPD to better understand their disease on a personalized level, to recognize specific triggers at which they should respond and how teach them how to respond, and then to assure that they have the tools to actually respond and self-manage or know when to seek care. And so a large group of us, supported by the Legacy for Airway Health, took this same concept and applied it to wildfire smoke. And then through meeting with multiple patient partners, realized that we had to incorporate heat into this because they're experienced at the same time, and created an action plan surrounding what individuals can and ideally would be counseled to do during wildfire smoke and extreme heat events. So this is, I'll go through parts of this as we walk through. This is publicly available for the Center for Lung Health. This has recently been written up and published in the BMJ Open Quality by a very talented medical student, Rose He. But this is publicly available for individuals to work through and then also for healthcare providers to access. And we've put together a provider guide that really supports healthcare providers in working through this with patients to go through and understand what's available locally in both Vancouver Coastal Health. And then we had also worked with respiratory therapists in interior health as well to create a model for them too. So I will run through briefly some of the guidance surrounding mitigation of exposure. So very important that individuals know how to check their air quality and temperature. So there are a number of different ways that this can be checked. This is available on the action plan with different recognizing that not everybody will want to check on an iPhone. Not everybody will be comfortable with that. Some individuals will want to listen to the radio. Some will want to check online. Others, there's actually a phone line in Canada called Hello Weather where you can call in and receive a weather report and receive air quality reports as well for those that prefer that approach. But very important that individuals know how to check their air quality and are doing so at least once a day, but ideally several times a day during wildfire season as conditions can change. And then understanding these activity recommendations that I showed on the slide previously. This is taken from one of those BC CDC info sheets and is color coded to the AQHI. Also has PM 2.5 values available for individuals who are using PM 2.5 rather than AQHI during wildfire season, and providing health messaging for individuals with the important caveat that folks should listen to their symptoms and decrease their activity and seek cleaner air should they be having symptoms at any of these categories. And we've incorporated this into the action plan as well with health messaging for me, so individuals can fill in based on their experience with wildfire smoke, what they know, and then also based on what is in the BCC guidance to sort of put this and have this readily available for themselves. We want to think about preparation as well. So many of these things are things we can get home and supplies ready in advance of wildfire season, such that when we do have smoke, as we know this is recurrent, we have the things in place and feel prepared for this. So thinking about individuals where it may not be advisable to leave the home, if they can create a safe and clean indoor air environment with air purifiers. So thinking about ways that they can stay indoors and have medications delivered to them or have an extra supply of medications, particularly those living with asthma and COPD who are at higher risk. Thinking about having a supply of well-fitting masks, and I'll just go through some of these, and then really dedicating a clean airspace within the home as well. Questions that I commonly get, and I'm sure many of us get, is how do I decide on an air cleaner? So there's a few options for this. I tend to tell patients and those that speak with me, really the most important thing is you get one that's HEPA that will really filter out the high concentration of that PM 2.5, and that it's rated to your space, meaning the square footage that it has the maximum efficiency to clean is the square footage of the room that you are planning to put it in. And then to avoid ozone producing products. So there are some that have what are called electrostatic precipitators within them. And generally, I advise my patients to avoid those because they can produce even small quantities of ozone, which have the potential for some health impacts. And then looking on the labels for those that are AHAM verified, which is the Association of Home Appliance Manufacturers. There's also the potential to build your own. So these instructions are available on BC Lung. They are available on the BC CDC website. There is a fantastic initiative by Anne-Marie Nicole, the Breathe initiative at SFU, where they will actually come out and do community events and teach people how to build air cleaners, but you can build your own. So with a box fan and several filters, typically MERV 13 or above, which are just a certain rating of the kinds of particles that they filter. So many more options becoming available for this. And indeed, the government of Canada, for individuals that have a severe chronic ailment, disease, or disorder, and particularly severe chronic respiratory ailment, will provide tax credits for, will allow you to deduct air conditioners and air filters, cleaners, or purifiers as a tax deductible medical expense. So that's important to tell your patients with a prescription. So if you are a patient, if you are someone who's living with this, ask your doctor for a prescription. And if you are a provider, provide your patients with prescriptions. And then there's a wonderful group, which Min Adibi is a fantastic PhD student who's doing a lot in the respiratory health space under the primary supervision of Dr. Mohsen Sadastabadi at UBC, who has looked at cost effectiveness of government rebates on portable air filters and demonstrating cost effectiveness in several scenarios. And in fact, I understand he's got some updated analyses coming out that may show even more cost effectiveness, though Dr. Carlston's involved with that, so I can let him speak to that if you'd like. And then I'm getting close to the end because I want to have some time for discussion, I know, but I do want to comment on masks because this is something that we think a lot about. We talk about getting a clean indoor airspace, and that's ideal, but individuals will have to go out at times, whether it's for they've been in their homes for weeks at a time due to smoke and just need to go out for one reason or another, mental health. Really, it's hard to be indoors for that long and not out and about. But how do we protect people when they're out in the world and it's a very smoky day? So masks and respirators are things that have I think there's more research that needs to be done, but there is some foundational research that is available, particularly in the occupational health space. On the left-hand side is really just a demonstration of a study of about 21 individuals where they looked at N95s and really understanding that one of the N95s or respirators are most effective when they're fit really well. So in the hospital, when we're going around to see patients and we have to wear an N95 to protect ourselves under certain infectious risk precautions, we have fit testing. Occupationally, we get fit tested. They make sure that we get fit tested annually and they make sure that there's really no leak or anything. But when we're recommending these for the public, we don't have the opportunity to do fit testing for everybody. So how do we increase the efficiency of this mask fit? And this is a study showing that individuals who, at least in this study, healthy individuals, the filtration efficiency of an N95 application was about 86%, which is pretty good. But even if you just give people a paper with instructions or a video with instructions, without the in-person instructions, you can substantially increase the fit and the potential protection. So again, going back to some of those BCCDC resources. And then this on the right, so this is a bit of a complicated slide, I understand, but let's go to the middle graph. And this is a modeling study looking at really putting masks over a tube that pushes particles through them and then measures how many come out the other side, and takes a look at different kinds of masks and how well they do at filtering the smaller particle sizes. So everything to the left of this red dotted line is the PM 2.5, so things that are below. And on the y-axis is the filtration efficiency. So the higher these lines are, the better filtration you're getting, the more particles that are being cleaned out. And so the highest is the purple. These are the N95s. But what we see here is that the surgical mask doesn't do terribly under ideal conditions. Now, recognizing that getting a fit with a surgical mask is imperfect, it's different. And so, but there's thought to be some potential moderate protection from just a triple layer surgical mask. And we don't see much protection at all from like cotton masks and so forth, natural masks. And then these authors went a step further, and they used this modeling in Washington State to look at admissions, and they applied the percent filtration that they saw of this PM 2.5. They looked at hospital admissions relative to wildfire smoke or attributable to wildfire smoke in Washington State. And they said if people were wearing masks a certain amount of the time, how much of a reduction in hospital admissions might we get? And it was pretty substantial, right? Again, a modeling study. There was a degree of error that they applied surrounding this to show that not everybody's going to wear a mask perfectly and so forth. But in this modeling study, again, not a real world study where they actually deployed masks, but in this modeling study, they saw some potential health benefits. And in fact, Ryan Huff, which you heard his name before, he's a PhD. Well, now he's Dr. Huff, has graduated from Chris's lab, and I had the opportunity to work with him as well, is now working and doing some really important reviews of the evidence, and has put out a synthesis of effectiveness of masks and respirators against wildfire smoke. And there's really not as many real world studies. In fact, no real world studies that are looking at the effect of masks, wearing a mask or respirator on health endpoints during combustion-derived air pollution episodes. So more research to be done, but because of that, some of the theoretical benefits that we see and some of the modeling studies before masks and respirators are recommended in the setting of high concentration pollutant events from wildfire smoke. And then third, we want individuals to have a plan and feel prepared during these events and so forth. So this is the third part of the action plan that's there. It talks about if you have to go outside, making sure you have a mask and so forth, where you might need to go, if there's a power outage, or if you're unable to establish cleaner or cooler air in your home. I'll highlight briefly a couple of studies that are moving forward. This is a study of Dr. Carlston's that is going to be starting to enroll. And this is within the air pollution exposure lab. So looking at that causal evidence, direct exposure of individuals who are living with COPD, and looking at the impact of inhaled steroids and how they may or may not have protective effects in the setting of air pollution. Really, we're not sure. And that's why these studies are being done. So there's the potential for inhaled steroids to reduce inflammation in the lung, and that could be potentially helpful in large strokes. But there's also the potential that they could reduce the ability to fight off infections and microbes and so forth. So really, we're trying to figure out, and Dr. Carlston and the lab is trying to figure out whether inhaled steroids could be a potential intervention in the setting of higher air pollution exposure events. Something that I'm very interested in is the potential of diet to plausibly change the way that we respond to air pollution. So this is a clinical trial that was done in 120 participants with COPD. It was a 3-year study looking at it, just advising folks in the intervention group to eat more fruits and vegetables. In fact, they increased their consumption by at least 1 serving per day. And if you look on the right-hand side, what you can see is those individuals who were able to increase their fruit and vegetable intake actually had they had more stability or less loss of FEV1 over time, showing some potential clinical impacts of this from an inflammatory standpoint and from a health outcome standpoint. And so, in collaboration with Dr. Carlston, we are now taking this to the lab, as well as with some other evidence, and looking to test the impact of a change in diet to a high fruit and vegetable, high omega-3 intake through the intake of salmon intervention to see if that changes individuals' response to wood smoke. So, more coming with that as well. So, testing ways to protect the population. And finally, I just want to circle back to one of the initial concepts that I started with is that planetary health is human health. Human health is planetary health. We are interconnected, inseparable. And really, there's a lot of amazing work being done, particularly in Canada, but by the Cascades Network, to try to empower patients and colleagues to think about the impact of healthcare on our carbon emissions and global warming. And I think this is particularly impactful as COP30 is starting today, which is the UN climate conference, has been going on for 30 years to try to understand and think about ways that we can reduce carbon emissions. So Cascades has put together a number of different resources for reducing carbon emissions as a result of healthcare. One is about inhaler disposal. So on the right-hand side is one of the posters and that can be put up in different clinics through Cascades. Pharmacies can sign up to be a part of inhaler disposal networks. And you can see through my map on the left-hand side that there's a number of locations in the Lower Mainland. But there's also, you can actually look this up on healthsteward.ca and see which pharmacies are able to take your inhalers after you've used them to recycle them and reduce emissions. There's also a new tool and resource that's come out from Cascades, which can help providers to understand the carbon impacts of different inhalers within BC. This is a really important and up and coming topic and one that's been talked about for quite a while, but I think is making its way into clinical practice. We recognize that there are carbon impacts of inhalers, particularly the metered dose inhalers, and dry powder inhalers and soft mist inhalers have less of a carbon impact. It's also important to think about the impact of admissions and the impact of additional healthcare utilization for those that are inadequately treated. So if that means that a patient does better with a metered dose inhaler, even if it's a higher carbon impact, we tend to choose the metered dose inhaler. So it's all about working with your patients to try to reduce overall emissions. And the Canadian Thoracic Society has actually put out a position statement on this as well. So a lot of great work being done in Canada. So with that, just want to circle back to some key points that we've talked about, both Dr. Carlston and myself. So acute effects, especially on asthma, as we were talking about, which is a disease of environmental health, but COPD as well, are increasingly established. We are having emerging observational evidence of the specificity of smoke and how smoke exposures may differ from other forms of pollutants, but experimental evidence is still limited. I highlighted some of that with the masks, but also as we're thinking about through some of the studies that Dr. Carlston noted. There are multiple occupational concerns. I would highlight a recent study from the New York Times, which has a great scan through about some of the impacts of health impacts on wildland firefighters in the US. It's a really great and informative read, and I think they did a good job. And that protection really needs active intervention. We should try our best to avoid, I think, where it is practical to do so and have some great guidance in doing that. But we also need to come up with ways to mitigate risk among those that are going to be exposed. We are all exposed to some degree. And we need to find out chronic effects to better have greater specificity in the health mitigation guidance that we have. So very much want to thank everybody for hosting us today. And I think we have hopefully some time for discussion.
Yes, we do. Thank
Sharing.
you, Dr. Brigham. Can you hear me?
Yes.
Okay, fantastic. Again, thank you both to our speakers for a great summary of the existing data on wildfire smoke and ways we can prevent wildfire smoke and the specifics of wildfire smoke. We have a large number of questions that have been asked and largely answered. Dr. Carlson has been monitoring the Q&A. I would remind folks that if you have new questions to ask, please put them in the Q&A section and not the chat. The Q&A is a better place for us to manage those questions. So, Dr. Carlson, you've already at, answered several questions. Is there a particular question you'd like to surface and just bring to the top? For instance, since we don't have any open questions right now, Mike Tuna asked quite early on, is there any difference between PM 2.5 smoke from wildfire versus domestic wood stove sources based on impact on human health? And I found your answer a little bit interesting. So folks can either look, I believe they can see the answers. But Dr. Carlson, do you want to speak on that?
Sure. And if by interesting you meant you might have some ways to beg to differ, that's fine too, because it is
No,
a
no, no,
pretty
no, no.
okay. Wasn't
Interesting,
code word.
interesting,
Okay.
and then I think the audience will benefit from
Oh,
the
okay.
information.
Cool. Because it is a kind of a controversial thing. But I guess what I'd say, or what I meant to say, and we'll summarize in a nutshell, is that um, well, two things. One is that we talk about fire smoke all the time, and we're talking about wildfires. Typically, it's kind of like dramatic and everything appropriately tends to focus around that, especially in the summer. But a lot of our um, fire smoke is actually from stoves. And I don't have it, but it's in one of my grant proposals where a large percentage, it might be 20 something percent of fire smoke exposure is actually from the stoves in people's houses, even though obviously wildland fires are massively important. So on the one hand, it's not a trivial amount of the fire smoke exposure we get, and I think we tend to forget that. And there's still kind of a romanticization of fires, and that's a whole socio-cultural political topic. But the exposures are real; they're important, and yet they're probably, ounce for ounce or whatever unit you want to use, probably less toxic. They're toxic. Don't get me wrong. The studies I showed from the human controlled exposures, and that review paper has more of them. Those are from just burning wood in a stove, just like very similar to people's homes. In fact, the Swedish studies often just use a regular old stove like you'd have in any home. So very, very similar, and yet you're seeing the toxicity. What I was just pointing out is that the fires in a wildland setting, especially if there's an urban interface, are very likely more toxic for the reasons I mentioned, multiple components. It sounds gross, but you're burning animals, you're burning all kinds of things, you're burning allergens, and that's even before you get to structures where there's paint and metal and plastic and all kinds of nasty chemicals. So, for all those reasons, we think that the pure fire smoke studies just would are an underestimate.
Yeah, so those controlled trials can't capture the real world complexities of those of the birds. Also, you did mention the aspect of the aging. I thought that was a nice subtle point you made. So we do have a new question in the chat. It is kind of related to a previous question. So maybe I'll resurface that previous question and bring up Jay's question. So there was a question on the island about the island. The question was directed to you, Dr. Brigham, but I'm happy to jump in as well. On Vancouver Island this summer, we had some days in local areas that were incredibly bad for air quality, as observed with purple air monitors and anecdotal observations. Yet the provincial AQHA monitor never registered into the high risk category. Why does the provincial AQHI not work in accurately capturing PM 2.5 readings? I realize it might be hard to speak to a particular situation. However, as I understand, the provincial reporting monitoring system rarely captures accurate AQHI readings of PM 2.5. The reason why I'm kind of bringing this up is there's a lot of um, kind of assumptions worth unpacking in those questions. So, Dr. Brigham, do you have a particular comment you want to add?
I'm not sure that I can comment on the specifics of those days on Vancouver Island, other than
Yeah.
I was monitoring that quite a bit and looking at the looking at the PM 2.5 values on that aqmap.ca, and all the purple air monitors and the federal monitors and so forth there. It is worth noting that the low cost sensors, including purple air monitors at the higher values, have some can have some increased error, and there are correction factors that have been investigated and can actually be applied, such that you may get a different reading between federal monitors and purple air monitors, that once you apply the correction factor, that sort of closes, that gap can close. So I can't speak to whether or not that was a specific event within that. And then I lost that. I know there was another question in there, but I think I lost it as I was thinking about that. I don't know if you want to step in, Dr. Coker.
Yeah, well, I think it's important to the AQHA now is used as the predominant public health messaging tool, as a predominant public health messaging tool. And so when we go to look at the BC environment site and we see what the AQHI is reading, just know that that is based on, kind of gold standard measurement of fine particulate matter and these other pollutants as well. Uh, and so when we switch to the purple air, you mentioned that, there's also an issue of time averaging where, if you go to the purple air map, it's just a value at a single minute, whereas the BC environment is showing you values over an hour. What is the average over the past hour? And from a health standpoint, the levels of air pollution for a given hour is likely more important for understanding and interpreting the information for health rather than a single minute. So there's another issue of discrepancy in addition to the additional error that is caused, or that is observed with the purple air sensors. Uh, uh, so that can explain some of the discrepancies. And then another one is, smoke does not disperse uniformly geographically. And so the purple air sensors are really supplementing where there are not BC air quality monitors. Just it's important for people to know that the air monitoring stations are for regulatory purposes. They're meant to capture ambient background air pollution levels. So they're not designed really to say, okay, what is the AQHI in this community? What is the AQHI in this community? Purple air sensor or low cost sensors more broadly are helpful to fill in those spatial gaps. And so in some cases where there's really sparse government air monitoring, purple air sensors may be able to detect these spikes. So I'd say those are three of the main reasons why you might see that. But just to close the loop here is the AQ map, which is run by Environment Climate Change Canada. They integrate all the purple air sensors data, all of the government regulatory air monitor data, as well as some AQ-AG data, low-cost sensors that we operate here at BC Center for Disease Control, and they correct those values from the low-cost sensors and they display it on our 1 hour averages. So what you're seeing is more of a apples to apples comparison between the regulatory monitors from the government and the purple air sensors. So that's AQ map. If folks want to look at the data with more like that's more relevant to your community. So I'll just put a plug in for that website where some of those issues are addressed. There's a lot of questions here coming in. And then, so there's a question from Jay about since AQHI is an index, and I believe this was addressed during one of the talks. Yeah, so AQHI is ozone, NO2, and PM2.5. Is it possible that when PM2.5 is elevated and the other two are lower, it causes AQHI to underreport risk? And so does anybody want to take just to reiterate that point about Emily?
Yeah, I'm happy to do that. So there was an update that was done several years ago by investigators at the BC CDC for just that reason that this commenter is pointing out, in that there was the risk of that, of it being underrepresenting risk in the setting of high PM 2.5 concentrations. And they don't always track together. And so it was called the AQHI plus, which was an updated equation that was meant to really prioritize the impacts of PM 2.5 within the equation and report that. And the AQHI plus has actually now been adopted as the AQHI during wildfire season. And so therefore it should not underrepresent the potential health impacts, with the recognition that PM 2.5 may be driving most of the health impacts during wildfire smoke season, and ozone and NO2 may be lower. So somebody else thought of that too. So great, but should be
Yeah.
addressed. Yeah.
Yeah, very
Yeah.
astute for somebody to pick up on, and
Yeah.
fortunately, it has been kind of partially addressed to a large degree in BC at least. Um, so there is a question that was answered, but we can resurface this one. Um, Thank you so much for the informative presentations. I have a wildfire science background and I'm an advocate for cultural and prescribed fire as a way to better coexist with wildfire and the fire-dependent ecosystems that many of us live within. I love the concept of mitigating exposure instead of mitigating all smoke, which ultimately we could not do in the long term. Dr. Carlston and Dr. Brigham, do you feel as if public education strikes the balance in emphasizing the need to adapt to the presence of smoke versus advocacy to eliminate wildland fire smoke from our communities? Are you learning about the need for cultural, prescribed, and general wildfire and ecosystems um, when exploring the health impacts of fire smoke? And I can repeat some aspects of the question if you need it.
Yeah, that's wonderful. And I think Dr. Carlson may have had to jump off, so I'm happy to jump into that one. It's a tough balance to strike, and I really appreciate this question because I'm not in forestry, but I've had the opportunity to interact with so many people who are through some of the collaborative work at UBC, and also to interact with a number of Indigenous knowledge holders, um, and really start to understand what kind of a role forest management and land stewardship has had in the fire seasons that we are experiencing now, of increased duration, intensity, and all the smoke that we are seeing. With recognition that there's multiple factors that are playing a role, but the suppression of prescribed burns through traditional practices are likely have contributed in some way to this. So, it's a tricky message to wield as a healthcare provider like myself, where we work to support avoidance of risk, particularly for those that are the highest risk. And certainly having prescribed any release of smoke into the air is the potential to to impact some of the patients and the individuals that I take care of, and impact other aspects of the population in ways that we don't know. And where is the balance between these more controlled, lower intensity prescribed burns versus these large wildfires that we see, where things are kind of like we've suppressed, and now we're having these really intense and prolonged fires. I don't know that the balance has been hit in how we discuss that with the public. I think scientific communication and health communication, public health communication, is incredibly complex. We saw that during the COVID-19 pandemic, and how we communicate risk budgets and risk sort of just things where decisions have to be made in the context of risk is really tricky. I think a lot was learned from that. But I don't know that we found the sweet spot yet. But I so appreciate bringing that into the conversation, because it's really like, how do we address these issues in a way where we are going to experience smoke? What is the best way for us to experience smoke, knowing that we're going to have it? Is it these prescribed burns? And is that really, if that's going to be ultimately better for our planet as well, we have to think about that in terms of the longer term health of ourselves and the planet too. So I don't know. Dr. Coker, do you want to add to that? It's very philosophical. I love this.
Yeah, it's philosophical, but also real world practical implications.
Yeah.
So it's a very nice, well-rounded question. I guess I guess our research, Chris isn't available right now, but I mean he did kind of make the point that that he and his colleagues have kind of moved away from the question of eliminating wildfire smoke because it's here and it's not going away. Um, uh, you know, it would be fantastic if these events stopped occurring. But when you think about population growth and more people moving into spaces where they're going to be coming into contact with the urban wildland urban interfaces, these events are going to keep on happening. Climate change is doesn't seem to be slowing down. So, certainly the adaptation and education piece to make communities more resilient are going to be critical. And so I think in my view, it is a reasonable assumption that um, wildfire smoke is not going away. And recent modeling efforts have shown that we expect increases in wildfire smoke. So kind of with that assumptions embedded, it does make a lot of sense to me to, make sure that people are, especially lung health patients, do know what they should do when and have the resources to respond when these events do occur. So I think that's always going to be important. Um, but I'm sure other folks have other perspectives on it, and very happy to hear those perspectives. Anything else on that point, Emily?
No, very well said. I like that.
Okay, great. Well, we are getting short on time. Uh, I think I'll just cover one more question because it gets to the issue of susceptibility, and I think you might be able to answer this.
Yeah.
Some people have argued that it is better to exercise during high particulate days than not to exercise at all. What are your thoughts on this, Dr. Brigham?
Yeah. I think we don't know yet. I think we're operating without all the data to say that. And then I think it as part of that argument, it's who is exercising.
Yeah.
So who who is the person that is putting them out there and breathing in greater concentrations of particulate matter, and how will it affect them? We know that when individuals do go out and exercise, right, or your minute ventilation, or how much air you are circulating through your lungs, how much particulate matter you're being exposed to, can go up to tenfold. And so when you're thinking about that in the setting of a certain PM 2.5 concentration in the air, and then thinking about what's actually going into your lungs and what your body is processing, we start to get into questions of like, what is your actual risk, when what we know is risk associated with a certain air concentration, but not necessarily a dose concentration in the lungs. So some of that work is being done, figuring this out. I will say, as a part of that Lungs on Fire group, Mike Cole, who is a professor at UBC, is doing some work looking at active commuters during wildfire smoke episodes to try to understand what some of the acute health impacts really are for individuals who are choosing to exercise during these events. I think these events are going to happen. We are going to have people continue to exercise during them. The Grand Fondo is the perfect example of that. That happened, and that event moved forward. And so understanding where the risk benefit line falls is really important. At this time, I suspect we're still going to we'll have a greater sense for a larger population, maybe for healthy individuals, but then we'll have to learn a bit more about that risk benefit for individuals who have different susceptibilities too. So long and short, I don't know. There's really good benefits to exercise. There are risks to wildfire smoke exposure, and where that risk benefit line crosses, we don't know.
Yeah, it would be nice if we knew the answer to all of these questions.
I know. Well, one day.
Yes, we will one day, hopefully.
Yeah.
So, and there's a comment here, is there a way to adjust exercise on the day? And I think ultimately that's probably, again, who is it? Is it somebody with, lung, respiratory, cardiovascular disease? They should strongly consider, I would imagine, changing their exercise patterns, maybe doing it indoors, accessing a gym where there's hopefully clean and filtered air. What is the temperature outside? Other considerations when trying to do this. But yeah, I think there's a lot of unanswered questions. So it's a really important topic, though.
Yeah.
Yeah. So I'm sorry. Go ahead.
No, I was going to highlight or sort of emphasize what you had just said about even within smoky days, if you choose to exercise, or if you need to exercise, mitigating risk within that. So like checking air quality changes within a day. So checking to see when the air quality is the best and so forth too. So I like that comment.
Yeah. Another plug for AQ Map. Look it up. Yes. Okay. So we've arrived at the end of our webinar for today. And so I would like to thank Dr. Carlson, Dr. Brigham for dropping all the knowledge on wildfire smoke and human health. This has been really informative. I'm not sure if BC Lung Foundation needs to say a formal goodbye here. But I really do appreciate the audience's participation and interest in this topic. This is not going away. This issue is not going away anytime soon. So the more people understand what fine particulate matter is, PM 2.5, the health risks, the better we're off going to be in terms of preparing our individually, collectively in British Columbia. So thank you everybody for your attendance.
Thank you. Thanks for the opportunity to come and speak and to all the comments and questions.
Thanks, everyone.